So hello everyone. कहाँ देख रहे हो तुम अपनी दीदी को? Where are you looking at your sister? Look at your brother. I am standing here. Just wait, I'll just come. All right, I'm Dr. Sourabh. Hello everyone, and I'm going to take one half of the DVT session. A very welcome to all of you, and I'm going to take this part in ophthalmology. I've been allotted this part. So starting with the anatomy and physiology, I'll start. You have your DVT workbook. Have you got another copy with you to write? Just raise your hands. Yeah, I can see every one of you. Oh, you have got. So keep that in the bag because that is not required. You can write everything in the workbook. Or even if you don't want to write, just sit and relax. You will get the annotated version as well, which I will write. The same thing you will get in the e-medi course. So I'll be dealing with this short, concised manner which is required in DVT. 1.5 hours is allotted to me for this. So smile, enjoy the session, but be observant. All right. So I'm going to start with anatomy, physiology, and basic investigations. So the first picture, let us see this anatomy. This is the eyeball, a section of the eyeball. The first question is a very simple question. What is this chamber of the eye? So this is nothing but the anterior chamber of the eye, that is from the posterior margin of the cornea till the iris lens diaphragm. Not the anterior segment, because anterior segment is from the cornea till the entire lens. This is the anterior segment of the eye. And what is behind the lens? That is the posterior segment of the eye, which contains the vitreous. Now there are three types of vitreous is the second question. Primary, secondary and tertiary. The primary vitreous is hyaloid vessel. This is the primary vitreous, which is hyaloid vessel. Hyaloid vessel is a blood vessel which is connecting the optic disc to the lens. It is present in a canal. The name of the canal you should know is known as Clockett's canal. That is the primary vitreous, which is known as hyaloid vessel. The main vitreous, the definitive vitreous, is the secondary vitreous. That is the main jelly of the vitreous. And the tertiary vitreous you have to identify. Tertiary vitreous are the zonules of the lens. That is the suspensory ligaments of the lens, which is connecting the lens to the ciliary body. So in your eye, in my eye, at this moment, we don't have primary vitreous, because primary vitreous hyaloid vessel, it degenerates by 8th month of embryonic life. It is not present at birth. If it persists after the embryonic life, that is known as persistent hyperplastic primary vitreous, which you have to identify, A or B. The answer is B. That is a hyaloid vessel joining the optic disc to the lens. That is persistent hyperplastic primary vitreous, and primary vitreous or hyaloid vessel is formed by mesoderm. So it is a remnant of mesoderm, because mesoderm forms the blood vessels. Now what is this? This is the diffuse picture in the slit lamp. This brown is your iris. Now there is a loss of iris tissue. Loss of tissue is known as coloboma. So this is due to failure of closure of embryonic fissure. Now embryonic fissure closes by 36 days of embryonic life. If it does not close, there is a structural defect of eye tissue, and the embryonic fissure is present inferiorly. So all the eyeball colobomas, either iris or lens or retina or optic disc, are always present inferior. Not the eyelid coloboma. Eyelid coloboma is formed due to failure of eyelid development. That can be superior, inferior both. But eyeball colobomas, every word is important. Eyeball colobomas are formed by failure of embryonic fissure. They are always inferior. Now anatomically, which segment is this? This is the anterior segment. Okay, this is the lens and these are the zonules. The space between the zonules is known as a canal of Hanover. And the space between the zonules and the vitreous, anterior vitreous, the other name of vitreous is hyaloid. Which hyaloid is this? Secondary vitreous. This anterior vitreous, anterior hyaloid and the zonules is known as, the space between is known as canal of Petit. Space between the zonules and the hyaloid is canal of Petit. So that is the first thing which you write down with the basic anatomy, the basic structure of the eye which you should know. Now let us see, how do we see? If you are seeing me, I can't see you right now, but you are seeing me. When we see any object, I am your object, the conversion, the light is coming from the object going to the retina. The light impulse is converted to nerve impulse. Means the light is coming like this. This is the retina. Light is coming like here, and the light is striking the D. D is what? The rods and cones. There is a impulse created in the rods and cones. The light is coming from the object going to the retina, creating an impulse in the rods and cones. This is known as phototransduction. From here the impulse goes from the retina and continuation of the retina is the optic nerve. It goes into the visual cortex, that is known as phototransmission. So here it is known as phototransduction. And this is physiologically happening at rods and cones by hyperpolarization happening in light, because light impulse is converted to nerve impulse. Glutamate physiologically is decreased, occurs at rods and cones. Rods works at night, cones work at light. Night vision is because of rods, light vision, day vision because of cones. Happening at rods and cones. From here the impulse goes backwards into the retina cells, into bipolar cells. From bipolar, these are cells of the retina, it goes to B. What is B? Ganglion cells. There's a controversy going on. Don't get into controversy. Bipolar, take it as first order, ganglionic second order. I know there is a controversy going on, right? Don't get into controversies. Bipolar first order, ganglionic second order. Ganglion is a cell body. The continuation of the ganglionic cell is nothing but the nerve fiber layer of the retina. So A is the nerve fiber layer of the retina, which continues to form. If we accumulate the nerve fibers of the retina, we get optic nerve. And from optic nerve, the impulse, as you saw in the video, goes into primary visual cortex, that is in the occipital lobe. That is known as phototransmission in 124 milliseconds. That is in short the visual pathway. I hope from optic nerve, you know, crossing of the nasal fibers in optic chiasma, then optic tract, then third order neuron, lateral geniculate body, then optic radiations passing through temporal parietal lobe, and then the visual cortex in phototransmission. I hope you know the third one from the class, photo regeneration. That is regeneration of the rods and cones in dark. Photo regeneration, phototransduction, phototransmission, these three things are happening in visual pathway. So I hope you can tell if there's a photo regeneration, that will be because of depolarization. D for dark, D for depolarization, and the glutamate should increase in depolarization. All right. Then when we see any object, like I am the object, you are seeing me. You are seeing me or not? If you can see me, you have a light sense. You can see the colors also. This is black, this is some pink or white. You can see the colors. That is called color sense. You have color sense. That's why you can appreciate the colors. You can see me in respect to the surroundings. That is a contrast sense. And what is the fourth sense? The fourth sense is a fill in the blank form sense. Means you can see me, right? Me as a human being, not any other pen, paper, pencil. I'm not a pen, paper, pencil. I'm a human being. You can tell the shape of the object. That is a form sense, and form sense tells about the visual acuity. Which Farnsworth-Munsell test is for color sense. It quantifies the color blindness. But the screening test for color blindness is the option number B. That is Ishihara test. So Ishihara test is B, and that is for screening test for color blindness. Both are subjective test. But the contrast sense is checked by this C. This is C, which is known as Paley-Robson chart. Now why Paley-Robson chart cannot be for color sense? Because the color is the same, black. The contrast is decreasing. Why it cannot be the visual acuity? Because the size of the letters are same. The size is not decreasing. So this is for contrast sense. These two are for color sense. Light sense just by throwing a torchlight. If you can see the torchlight, that's a light sense. And form sense, that is visual acuity. And the most common chart for the form sense is this chart. This cannot be for color because the color is the same. The size is decreasing. The shape is changing of the letters. This is the most common chart. Everyone should know Snellen's chart. Now Snellen's chart is done from 6 meters. That's why the numerator everywhere is 6. Now this is for the form sense. Now what's the meaning of this numerator? Distance of the patient from the chart. And the denominator is the distance from where a normal person can see the letter. Means the first question, the 6 by 60 letter can be seen by a normal patient from 60 meters. 636 can be seen by a normal patient from 36 meters. Now it's based on the concept of minimal angle of resolution. The letters are subtending some angle in the eye. How to calculate the MAR? Just reverse the visual acuity. 6 by 60 reverse is 10 minutes. 6 by 36, 6 minutes. 624, 4 minutes at the eye. But the entire letter, whether E, D, every letter can have 5 segments. This MAR is from only one segment. If the entire letter is asked, how much this angle is subtending by the entire letter, you have to multiply the MAR by 1, 2, 3, 4, 5 segments for knowing the entire letter angle subtended. So this question, this line is 6 by 12. The MAR of 6 by 12 is, we are good in maths, 12 by 6 is 2 minutes. But the entire letter you have to multiply by 5. Why not 4? Why not 6? Who told you this? Not me, Snellen's told. Answer is 10 minutes is the answer. But this Snellen's chart cannot be used for illiterates. For illiterates, this is also based on MAR, Landau's C chart, E chart. Landau's E chart, C chart, tell for illiterates. This is also for form sense. This is also for form sense, but this is not Snellen's chart. This is ETDRS chart. Early treatment of diabetic retinopathy study. Full form should be known. This is done from 4 meters. Answer is 4 meters. It is better for lazy eye people. You know who is lazy eye? Not lazy person. Not lazy eye amblyopias. Because they have a phenomena, crowding phenomena. So it is better for research purpose, better for amblyopias. All these are for form sense subjective tests. Now if you want to examine the eye, you have to objectively examine the eye. There are 4 devices I have given. One is indirect ophthalmoscopy, one is slit lamp. If this indirect ophthalmoscopy is also known as fundoscopy. It's a binocular test. So this is a uniocular test. It's a direct ophthalmoscope. And this is slit lamp, but the doctor is having some lenses in his hands. So this is slit lamp plus lenses. Sometimes you can call it as slit lamp biomicroscopy. Slit lamp, only with the help of slit lamp you can see anterior 1/3 of vitreous. Means up till the anterior 1/3 of vitreous. Means anterior segment you can see, anterior 1/3 you can see. Means if the patient has cornea problem, lens problem, cataract, anterior 1/3 of vitreous problem, slit lamp can be used. For the optic disc and the central retina, macula, direct ophthalmoscopy and slit lamp biomicroscopy can be used. But the gold standard is slit lamp biomicroscopy because it is a binocular test. And this fundoscopy, the other name of fundoscopy, fundus is retina, it is for the entire retina. Means if the patient has diabetic retinopathy, hypertension retinopathy or retina detachment, fundoscopy to be done. But if the patient is having central retina problem, age-related macular degeneration, what to choose? D to be choose. Why not direct? Because direct is a uniocular test. The doctor will not have 3D vision. For glaucoma, you need to have optic disc evaluation. So for optic disc and macula, again answer is slit lamp biomicroscopy. For retina tear, you have to do fundoscopy. B should be the answer. And whose eyes is this? I will end with this. I will end with this picture. Someone's eye. I will tell you later, or you can identify if you can. If you want to see this, this is just by slit lamp, which is used for this picture, only slit lamp, because this is just showing the anterior part of the eye. Slit lamp can be used. Slit lamp only can be used for anterior 1/3 of. Now what is done over here? See, the video is not there. Don't worry. Just see what is it. This is, I have direct ophthalmoscope in my hand and I am showing a torch direct ophthalmoscope. There is a source of light from a distance. This is not direct ophthalmoscopy. This is distant direct ophthalmoscopy. It will help me to know the reflex in the patient's eye. The red reflex at the center of the pupil. Normal is red. Leukocoria, white reflex, most common cause congenital cataract, can be seen in retinoblastoma. This is not in the PDF, just some extra point. Distant direct ophthalmoscopy, as the name suggests, from a distance. Oil droplet reflex, keratoconus. Oil globular reflex, anterior lenticonus. There is a question also that. But now when I come as close to the patient as possible, don't get me wrong, this is direct ophthalmoscopy. This is distant direct, from a distance, only for the reflex, no image. Then we come as close to the patient as possible, then it's a direct ophthalmoscopy. And my question to do is, which is correct? This I am doing is correct or this is correct? Means if you want to see the right eye of the patient, you will choose which eye? Right eye or left eye? Which is correct? If you do this, then there is a problem, okay? To see the right eye of the patient, you should see from your right eye. If you see from the other eye, then I hope you can understand a little bit of this. So now let us see all 4 pictures I've given from the slit lamp. Slit lamp can we have a slit picture or a diffuse picture? This is diffuse picture. This is a slit picture. Let us see one by one. Let me zoom it. Which part of the eye as being shown over here? If you throw a light, this is at the surface of cornea. So this is your cornea and this part is your lens. I am zooming it again. Any problem do you see? Any problem in the lens or cornea? No, there is no abnormality. This is artifact. Don't ask me, sir, what is a yellow? This is arrow, this is artifact. No abnormality in this picture. Let us see the abnormality over here. See, what is this? This is cornea. Okay, this is what? Cornea. This is the lens. The anterior part of the lens is curved. This is a problem that is seen in a condition known as anterior lenticonus. And just now I told you, by distant direct ophthalmoscopy, anterior lenticonus will have not oil droplet, oil globular reflex. And which systemic condition? A young patient, hypertension, blood in the urine, Alport syndrome, has deafness, urine, blood, anterior lenticonus. Again, what is this? This is cornea. This is the lens, anterior part of the lens. The center part of the lens is having some density increase. So which part is involved? The center part of the lens is involved. The center part is known as nucleus. And here, if the density of the, if it is sclerosis, means the density of the center lens is increasing, what will happen? The ray of light will come and converged before the retina, because the density of the lens is increasing. I know physics, physics, we are good in physics also. The light is coming and throwing and going from a denser medium, it will be forced to converge. Converge before the retina means patient will get which refractive error? He will get this refractive error, that is myopia. And myopia is short-sightedness. Patient can see near things better. So patient having nucleus sclerosis will have decreased far vision, improvement near vision, and that is known as second sight phenomena. Second sight phenomena in nucleus sclerosis patient. What is this? Light is going behind. This is hypermetropia. Focus at a single point. Any astigmatism here? No, because all the rays are focused at a single point. This is simple myopia and this is emetropia, which you call normal. What is the diagnosis over here? Again, a very important picture. This is the cornea. This is the anterior part of the lens. This is the posterior part of the lens. The posterior part of lens is having opacification. This is the condition known as posterior subcapsular cataract. And posterior subcapsular cataract, what symptom? Patient will have decreased vision and he will complain of when he drives at night, he's having problem in seeing the incoming light, that is known as glare. So patient will complain of glare in posterior subcapsular cataract. In the class I tell you how to remember the differentials. PSC is seen in BSC. What is B? Busulfan. It can be seen in busulfan. It can be seen in blower's cataract, that is radiation cataract. Steroid, a very, very important example. BSC, C, chloroquine, complicated cataract due to intraocular pathology like uveitis, and last one, cupuliform senile cataract. That is the differentials of posterior subcapsular. Now these four, as I told you, are diffuse images of the slit lamp. In the first picture, if you see, only the periphery of the lens is having opacities, not in the center. So that is a cortical cataract known as cuneiform cataract. Now this is the most common shape of senile cataract. This one. I have written immature senile cataract. How to differentiate immature from mature and hypermature? This is Morgagnian. How to identify Morgagnian? This is the nucleus because of increased density of the lens, which is dropping down in the lens. That is Morgagnian hypermature type. Mature and immature, this arrow I have given. How to differentiate? If I zoom it, this you can see there is a shadow. Black thing is shadow of the iris on the lens. That can be seen only in immature senile cataract, not in mature or hypermature. And as we go from immature, mature, hypermature senile cataract, the size of the lens is decreasing. As we are going from immature, mature, hypermature, what is happening? The vision is further decreasing. The size of the lens is reducing. Lens size decreases. The visual acuity decreases. The anterior chamber becomes more and more deep. You think, imagine if the lens is small, the anterior chamber, the first question, and anterior chamber become deep. So which of these has a least vision loss? Of course, senile cuneiform, because it is in the periphery. Which is the highest vision loss? Hypermature. Which is leading to phacolytic glaucoma. If this is your eye, cornea, this is the iris. If the lens is very shrunk and this is the hypermature Morgagnian, lens protein can come out and block the trabecular meshwork. That is secondary open angle glaucoma seen in hypermature Morgagnian. Which has the deepest anterior chamber? I told you, Morgagnian. Now, if there is a cataract, you have to do cataract surgery. One cataract surgery is very important. That is, these are steps of which surgery? What is this step first? This is an animation. Okay, this is a red reflex coming from the retina. And this is a circular opening in the anterior capsule known as anterior capsular rhexis. A dye, blue color dye can be used here. Here it is not seen, it is just animation. But triple blue dye can be used. This is making in the opening in the anterior capsule. Here you are putting a saline or a syringe under the capsule. This is hydro dissection or delineation. Dissection, that is contraindicated in posterior polar cataracts. Why? Because posterior pole has the thinnest part of the lens. If you give by force, there can be rupture of posterior capsule, leading to the dropping of the nucleus into the vitreous. What surgery and what is the step? The step is phacoemulsification. Surgery is phacoemulsification. You break down, emulsify the nucleus into small pieces by conversion of electrical into mechanical energy, because they have some crystals, piezoelectric crystals, lead zirconate, which converts the electrical into mechanical energy, breaking the lens into small pieces, which can be aspirated inside the phacoprobe. And then you place the intraocular lens implantation, and the best position to place the intraocular lens implantation is in the posterior chamber of the eye. That's why it is posterior chamber intraocular lens. So this surgery is phacoemulsification. The incision in phacoemulsification is at the clear cornea or limbus. Incision is 2.75 to 3.2 millimeters. All right. Now, when you do cataract surgery, post cataract surgery, three differentials of high IOP and shallow AC can be there. One, you can see over here, there is a block of pupil and the lens. The entire 360 degree, the pupil is blocked. See, the ciliary body is producing aqueous. Aqueous cannot go to the anterior chamber. It is pushing the iris 360 degree. That is iris Bombay, known as pupil block glaucoma. And that is relieved by, what is the treatment? What am I doing? Treatment is laser iridotomy. Next picture, if you see the arrows, the aqueous is not going into the posterior chamber. It is going misdirection into the vitreous, causing increased vitreous pressure, pushing the lens iris upwards. This is aqueous misdirected glaucoma, malignant glaucoma, because very difficult to control. You have to take out the vitreous. Na rahega, vitreous na rahega from the class, right? Malignant glaucoma is treated by vitrectomy. If there is no vitreous, there is decrease in the vitreous pressure. And the third differential is The space between the sclera and choroid is known as suprachoroid. There is a vessels known as posterior ciliary vessels. Due to sudden fluctuation of intraocular pressure, there is posterior ciliary vessels rupture leading to suprachoroidal hemorrhage. It is the most dangerous complication of cataract surgery. It will push everything outside the eye. What can you do for this? Nothing. Just pray. Pray that it stops. But the first step can be tight closure of the incision in suprachoroidal hemorrhage if it is intraoperative. Post-operative, it manifests as shallow AC and high IOP. But what is the answer of shallow AC and low IOP? Very logically, if the wound is leaking, incision is leaking, aqueous is coming out. If the aqueous comes out, the pressure decreases, anticipation becomes shallow. How to know the aqueous is leaking or not? By serial test. Which dye you put? Fluorescein dye. Fluorescein dye is a orange color dye, and you see fluorescein dye under which light? There is a question also that later on, cobalt blue filter. If the aqueous is coming out, the dye will become diluted. If the dye is getting diluted, serial test is positive. So wherever you see in the question, in the exam, serial test is positive, what do you have to do? Resuture the wound. The treatment should be serial test positive. For wound leak, resuture the wound in operation theatre. Don't do in OPD. But post-cataract surgery decreased with glare. Glare, this is seen in posterior subcapsular cataract also, but this is post-cataract surgery with the same symptom. This is the most common complication of cataract surgery. After cataract, which pearls? Elschnig pearls, PCO, treated by ND-AG laser capsulotomy. That is the most common complication of cataract surgery. What sign is this? After cataract surgery, you see the sign. This is hypopyon. Identify, pus in the anterior chamber. It can be due to infection, acute endophthalmitis, or toxic anterior segment syndrome. It is due to infection. So most common organism is staph epidermidis, causing infection after 2 to 5 days of cataract surgery, painful vision loss, painless vision loss, because this is only inflammation in which segment? Anterior segment. Inflammation to IOL material. And by definition of endophthalmitis, vitreous has to be involved. And see this first question, anterior segment I told you from cornea to lens, vitreous has to be normal. That is why if you do ultrasound B scan, A scan for axial length, B scan will be normal in TAS. B scan will be in abnormal in endophthalmitis. Intravitreal injection of antibiotic. If it is not resolving, you have to do vitrectomy. Non-resolving, vitrectomy to be done. For TAS, answer is only steroids, because it only inflammation condition. So see this patient, chaddi pehen ke aa gaye hain ji. Tall, long arm, which habitus? Marfanoid habitus. Well, let us see the first picture. This is the reflex coming from the retina. You see in the center of the lens there is a reflex. Urine reducing substance. A child with urine reducing substance, oil droplet cataract, urine reducing galactosemia. Galactosemia is not related to Marfanoid habitus. What is this? There was a patient. I saw a patient. I shook his hand. He was not releasing the grip. What is this? I made him sit on slit lamp. वो छोड़ ही नहीं रहा था, मैंने उसको slit lamp पे बिठा दिया. Slit lamp पे I saw Christmas tree cataract, myotonic dystrophy. Difficult to release the grips. Christmas tree cataract, not related to Marfanoid. This is a patient with jaundice, basal ganglia, liver, basal ganglia, rigidity, eye problem, cases stresses in the cornea, sunflower cataract, Wilson's disease. Can also be seen in intraocular copper chalcosis. So this is also not related to Marfanoid habitus. Marfanoid habitus leads to this. What is this? This is the lens going up and out. Supratemporal subluxation of the lens, and that is mostly seen in Marfan syndrome. Supratemporal subluxation. Now, this is the answer over here. But if Marfanoid habitus is there and the patient has inferonasal subluxation, that is homocystinuria. Homocystinuria, the important point is he has broken, not heart, broken zonules. Broken zonules are there in homocystinuria. Both Marfan and homocystinuria has Marfanoid habitus. Same tall arm, supratemporal in Marfans, inferonasal in homocystinuria. Marfan fibrillin gene, pathology, homocystinuria, cystathionin beta synthetase enzyme problem, biochemistry. All right. Now let us see very, very carefully what is happening over here. There are two axes, two rays in two axes are shown. Red one is a vertical axis, horizontal axis is the blue one. Vertical is focused at this point, horizontal focus at this point. They are not focused at a single point, means there is astigmatism. This principle is a Sturm's principle. Sturm's is a principle of astigmatism. Now, why is the ray of the red is focused in front? Maybe the cornea of that axis is more steeper. So vertical axis is steeper over here, and by definition vertical steeper is known as with the rule astigmatism. That is by definition. Horizontal steeper known as against the rule. So vertical is steeper over here. Now if the retina of the patient is at point number G, if you have to assume, student asks, sir, where is the retina? You have to assume the retina. If the retina is at point number G, both the rays are focused in front, compound myopic astigmatism is there. If the retina is at point number C, D, E, one in front, one behind, mixed astigmatism. If the retina is at point number A, for example, both are behind the retina, compound hypermetropic astigmatism. That is the concept of Sturm's conoid. The best vision in Sturm's conoid is mixed astigmatism because equidistant from both the converging points. Now what is the astigmatism? There is astigmatism, yes, because there are two rays, maybe one vertical, horizontal, not focused at a single point. Both are in front. This is compound myopic astigmatism. Now you cannot say with the rule against the rule because you don't know which one is a vertical, which one is horizontal. Only you can say that this, for example, X ray and Y ray. X is the steeper. X is steeper, that's why it is focused in front. But you cannot say with the rule against the rule. Here you can only say compound myopic because you don't know X is vertical or horizontal. But here you can say, what's the meaning of this? -4 means the ray in the vertical axis must be focused in front, and +4 means the ray must be focused behind. So this is mixed astigmatism, and now -4 is more steeper axis because it is focused more in front, and -4 is in the vertical. Vertical, I told you, is with the rule astigmatism. Vertical is steeper, with the rule mixed astigmatism. Now if you get a prescription of glass like this, by simple mathematics and English you can solve. What is the meaning of the word spherical? +2 diopter sphere means +2 is working in both the axes, and -1 cylinder at 90 means it is kept at 90 degree, it is working in horizontal. How much? -1. Now do the maths. Spherical means it is working in all the axes. Cylinder property you kept in 90, it will work in horizontal and vice versa. So it becomes +2 +1. +2 +1 means both the rays are focused behind the retina. Now which one is steeper axis? +2 will be more behind. So +2 will be more behind. +1 is more steeper axis. +1 is in horizontal axis. This is compound hypermetropic astigmatism against the rule because horizontal is focused more in front. That is how you take the prescription of glasses into the refractive error. Now what is the meaning of the word transposition? You have to bring such an equation which has the same +2 in the vertical and +1 in horizontal. How to get a simple thing? The spherical and cylinder power you numerically join. It will become +3. That is the spherical of the next. Just change the sign of the cylinder. See, +1 become -1, -1 become +1. And just change the axis from 90 to 180, 180 to 90. So +2 -1 maths. +1 is a spherical of the next. Change the sign of cylinder, -1 +1. Change the axis from 90 to 180 and you convert this. Ghar jaake you can convert this into, you will get this +1, +2 and +1 over here. But some people don't like cylinder. They prefer, I don't like cylinder, I want only spherical equivalent. Equivalent means only spherical power is there. How to get this equation or this equation? Spherical equivalent will be same because they are both same equation. How to get? Take the spherical power as it is, half the cylinder, numerically join. That is the method. Spherical +1 as it is, half cylinder means +0.5, +1, +1.5. Respect the signs. Answer is +1.5 diopter spherical. No at the rate. At the rate means 360 degrees. Spherical means 360 degrees. You take the spherical equivalent of this. It will be same. This one. +2 as it is. -0.5. +2 -1.5. We are good in mathematics. +1.5 diopter spherical is the answer. Spherical equivalent of this question. Now, keratometry. This is keratometry. Keratometry gives you corneal curvature. Now corneal curvature, normal corneal curvature is 44 diopters. The more the corneal curvature, the more steeper axis. So 47 is more steeper over here. This is not just refractive error. This is refractive error. +4 and +1. Both are plus, both are behind the retina. +1 will be more in front. So this is compound hypermetropic against the rule, and here the horizontal is steeper because +1 is more in front. This is not refractive error. Have you seen anyone having -47 degree spectacle? ऐसा देखा किसी को? इतनी बड़ी फुटबॉल आईज और a very +47 hypermetropic mutter P eyes. This is not refractive error. This is the refractive error. This is keratometry. The more the corneal curvature, the more steeper axis. They can ask from keratometry in radius of curvature also. I hope you know from the class, the smaller the radius of curvature, the steeper the axis. So, for example, if I give you extra question, 6.7 and 7.6 millimeter radius of curvature, 6.7 is more steeper axis. Here answer is with the rule. The smaller the radius, more curved the surface. Now, what are the changes in the eye during this? What is this? You're reading. That is near vision, also known as accommodation. Your eyes are accommodating for near. So what happens when the eyes are relaxed? If you want to see any object, the rays are focused on the retina. When the object is coming near, the rays are focused behind the retina. To bring this image onto the retina, the lens has to work. Lens has to converge the image. So what is the meaning of accommodation? The converging power of eye should increase. How? The ciliary body contracts, zonules relax. The curvature of the lens anteriorly increase. That increases the converging power of eye. Ciliary body contracts, zonules see are relaxing. You tell me anterior depth will be shallow because the lens anterior curvature is towards the cornea, shallow. Horizontal thickness increase, vertical thickness will decrease. That is accommodation. But this is because of lens. As we age, the lens become rigid, cataract. So this decreases with age. That is known as presbyopia. And mostly it is manifested after 40 years of age. And which refractive error? You know hypermetropia. I just told you simple hypermetropia has difficulty in rays are focused behind. He has difficulty in far vision also, please. And when the object comes near, the rays are more behind. So he is accommodating more to see the far and near. That is why hypermetropia are more prone for. With accommodation, eye goes inside. They are more prone for which squints? Convergent, iso squints. For treatment of presbyopia, you have to give additional near glasses. And this is bifocal, specifically executive type bifocals because there is a horizontal line. Upper one is for the far vision. Lower is always for near vision. Lower is always plus because that has to be converging. Upper one depends on myopia, hypermetropia or emetropia. So this is indication for presbyopia. Even in presbyopia you can give executive. Executive is a shape. Bifocal is the answer. It has to be given after the surgery of congenital cataract. Because accommodation is lost after cataract surgery, upper one may be 0 power, lower is always plus. And non-refractive mixed esotropia is the answer. The third one is non-refractive mixed. Non-refractive and mixed, what is this? E? Esotropia. Dash I gave you, no? Because they want for near relax their accommodation, so near glasses has to be given, but you can't explain the child. Remove your glasses for far and read glasses, wear glasses for near. So you have to give bifocals in a child. Even after congenital cataract surgery, you have to give bifocals. Even if the for far it does not require any glasses. So maybe 0 power for above, plus is always for below. Even in congenital cataract and in refractive esotropia. So 3 indications of executive bifocals. Even presbyopia is an indication of executive bifocal. Now what is being tested over here? What is this? What is this black thing? What is this? This is visual field you are checking. Whenever the visual field checking, you have to stand like this. Means you have to interpret as a patient's view. And in the patient's view, in the temporal side, there is a black. This is the blind spot, and this blind spot is because of optic disc. It is not optic disc. This is due to optic disc. Optic disc is nasal in the retina. That's why blind spot isn't temporal in the visual field. Everything which is nasal in the retina correspond to temporal. Everything superior in the retina correspond to inferior. Vice versa. They have retina fibers also. I given the question also. What is this? This is which visual field? This is the right visual field. This is the left. See, the blind spot is on the temporal side. This is the tunnel vision ring scotoma. So this is the right visual field because it is a patient view. Blind spot always on the temporal. This is tunnel vision ring scotoma differentials which dystrophy? Rods and cone dystrophy, retinitis pigmentosa. One gyrate dystrophy also not very important. Pan-retinal photocoagulation, very important. Two drugs, V batao, tell me. Yeah, I'm listening. Vigabatrin, quinine, and it is seen in late glaucoma. Seen in late stages of glaucoma. Which eye is this? Which visual field is this? This is a blind spot. This is the left visual field. Only the superior part. This is known as altitudinal defects. When only one half of the visual field is involved. So which part of the retina must be involving? The inferior part of the retina must be involving because the visual field defect is superior. Maybe inferior retina detachment, maybe non-arthritic ischemic optic neuropathy, maybe inferior retina detachment, maybe inferior branch retinal vein occlusion, maybe non-arthritic ischemic optic neuropathy, maybe some drusen's of the optic disc. Optic disc drusen's inferiorly also can cause this. Inferior retina detachment, inferior branch retinal vein occlusion, non-arthritic ischemic optic neuropathy. Optic disc drusen's is not asked in the exam, but optic disc drusen's inferiorly can also lead to superior visual field defects. This is what I'm talking about. When a picture is given to your retina like this is the observer's view. So this is the optic disc, this is the central retina, the fovea. Fovea is on the right side. So this is the right retina fibers, observer's view. These A and B fibers are arcuate fibers, superior and inferior arcuate fibers. All these are nerve fiber axons of the ganglionic cell coming to the optic disc, forming the optic nerve. Then chiasma, trach, visual cortex in 124 milliseconds. This is the optic disc as papilla, maculobundle fiber C. And D, radiating fibers are the most resistant in glaucoma. That is why temporal vision is the last to be involved in glaucoma. Which visual field is this? This is the blind spot. This is the BS means blind spot. This is the right visual field, central cecal scotoma. This is involved in optic nerve disorders. So papillomaculobundle fibers are involved. Then centrocecal scotoma can be there. Central only will have this one. Centrocecal when the entire visual field is the defect is joining the blind spot and the central. Papillomaculobundle fibers are involved both in central and centrocecal scotomas in optic neuropathies like in toxic optic neuropathies, alcohol amblyopia, tobacco amblyopia, central optic nerve disorders. But this is the right visual field because this is also blind spot. Again, right visual field. This is not central. It is paracentral scotoma. So this is right. Paracentral scotoma is the first visual field defect of glaucoma. Here in this specifically, which part of the retina might be involved? This is supranasal. So tell me, inferotemporal fibers must be involving. That is leading to supranasal paracentral scotoma, first field defect in glaucoma. Last field defect is temporal. And this is abnormality. Both visual fields, the blind spot are enlarged. Blind spot are enlarged. That can be seen in papilledema. Papilledema when there is optic disc edema. Bilateral optic disc edema due to high CSF pressure. And you know the cause in high CSF pressure is in the brain. Then you call papilledema. That can lead to bilateral enlargement of blind spot. Also enlargement of blind spot can be seen in myelinated optic nerve fibers. Myelination stops at the optic disc. If the optic nerve fibers, retinal nerve fibers are myelinated, there is enlargement of blind spot. Enlargement of blind spot is not seen in glaucoma, please. That is wrong, you study somewhere. So bilateral optic disc edema will lead to bilateral enlargement of blind spot. Also it can be seen in, tell me this question, if the patient has high CSF pressure, bilateral optic disc edema, bilateral blind spot enlargement, but you don't know the cause. MRI is normal. Then it is pseudotumor cerebri, idiopathic intracranial hypertension. So IIH, pseudotumor cerebri, papilledema, myelinated nerve fibers can be differentials of enlargement of blind spot. 5 questions from here. This is the right eye, this is the left eye. Right optic nerve transaction lesion is there. So patient will have total loss of the visual field of the right eye, right anopia. What is this? The patient can see in the nasal. He cannot see temporal. Bitemporal hemianopia seen in optic chiasma lesions because optic chiasma nasal fibers are crossing. And this is your cavernous sinus. Pituitary gland is above the cavernous sinus and optic chiasma is above the pituitary gland. So if the tumor is coming from above, there will be inferotemporal defects like in craniopharyngioma. In pituitary tumor, the tumor is coming from below, there will be superior temporal defects. So optic chiasma is homonymous or heteronymous? Heteronymous. Heteronymous means opposite side lesions. This is homonymous. Homonymous means same side. So this is what? This is left homonymous superior quadrantanopia. This is pi in the sky. This is, sorry, right homonymous. Right homonymous superior quadrantanopia, pi in the sky because of left temporal lobe lesions, because in the temporal lobe only inferior radiation fibers are involved, so superior defect is there. This is homonymous. And if the lesion is in the visual field of the right side, it has to be left homonymous, but macula is spared. Why macula is spared? Because the macula fibers have additional supply from middle cerebral artery. So this is right and left visual field defect, left homonymous heminopia with macula sparing is the answer, which I am drawing like this. If there's a left homonymous heminopia without macula sparing, then the answer is this, optic tract lesion. This is the congruous. Congruous means symmetrical defect. This is optic tract lesion. Right optic tract lesion will lead to left homonymous heminopia. There is no macula sparing. So visual field defect can be unilateral, bilateral. Unilateral, where was a unilateral? Only in your level unilateral is optic nerve lesion. Rest are bilateral. Then homonymous versus heteronymous. Heteronymous is only one, optic chiasma. Example of optic chiasma, craniopharyngioma, pituitary tumor. Then visual field defect can be congruous, non-incongruous. Congruous means symmetrical. This is symmetrical. All are symmetrical. Only two can be asymmetrical. One optic. This is anterior chiasma syndrome. This is asymmetrical. Asymmetrical because one is 100% involved, other is 25%. This is anterior chiasma syndrome. So chiasma defects can be asymmetrical. Even optic tract lesion can be asymmetrical. Symmetrical example I have given. This is an example of left homonymous heminopia which I am drawing, but incongruous. Congruous, incongruous, both can be seen in optic tract and chiasma. Anterior chiasma. This is left anterior chiasma syndrome. Left side total vision loss, other side supratemporal vision loss, because in the class I tell you, because of the Genio Willebrand, inferonasal fibers are involved. So other side supratemporal lesion is there. Just remember, congruous, incongruous means symmetrical, asymmetrical. Only two examples of asymmetrical, incongruous at your level: optic chiasma, optic tract. Okay, so which pathway is shown over here? What is 1, what is 3? So see the arrows. What is happening? The arrow is coming, crossing at the chiasma, and this is going into the midbrain. And then 3 is coming from both sides and causing pupil sphincter, means constriction. So pupil constriction is by parasympathetic pathway. If you throw light over here, who will take the impulse? Optic nerve. That will go to optic chiasma, optic tract, and then it will not go to LGB, it will go to pretectal nucleus in the dorsal part of midbrain. From here the pretectal goes to bilateral third nerve nucleus, Edinger-Westphal, and then the efferent is bilateral 3 is third nerve. It will come to ciliary ganglion, postganglionic fiber, short ciliary nerve, passing through fibers of the inferior oblique and causing bilateral pupillary constriction. You are shining light in one eye, both pupils are constricting. That is a light reflex, parasympathetic reflex. Now clinical point. See, if there is a left optic nerve lesion, this is the right, this is the left. If there is a left optic nerve lesion and you show light in the right eye is okay. Right eye optic nerve and third nerve is okay. Right eye will constrict. Left eye will also constrict. Both will constrict. But if you throw the light in this eye, afferent have the problem, then neither eye will constrict. That is seen in optic nerve lesion. But if there is a third nerve lesion on the left side, the third nerve lesion is there, and you throw light in the right eye, what happens? Right eye will constrict, but left eye cannot constrict because the efferent is having problem. Only the right eye will constrict. And if you throw in left third nerve palsy in this eye only, this cannot constrict because the efferent having problem, but consensual will be seen over here, yes or no? Light is thrown here, it will take the optic nerve, pretectal. Of course, third nerve will take the impulse here. So again, only right will constrict. That is seen in left third nerve. And what is this RAPD, relative afferent pupillary defect? That is The first Marcus gun pupil, the first sign of optic nerve compression is Marcus. What is written over here behind me? Gun pupil. Swinging flashlight examination is the first sign of optic nerve compression, optic neuritis. That is nothing but RAPD. That is Marcus gun pupil. Okay, now think logically. When there is a third nerve palsy or ciliary ganglion having lesion or sphincter is not working, what happens? The pupil will constrict or dilate? Dilate, mydriatic pupil. Ciliary ganglion lesion is known as AD's pupil. So see in this picture, in dark pupil should dilate, both are dilated, we don't know the difference. Difference of pupil is known as anisocoria. In light, the left eye is constricting. Okay, left eye is constricting. Right, this is the left. Left is okay, it is constricting. Right is not constricting. So the problem is in the right. In parasympathetic, because right is not constricting with light, it's a parasympathetic problem. Answer can be either the lesion is in the ciliary ganglion, that is AD's pupil, or third nerve palsy, damage to iris, sphincter. Or pharmacologically, if you put atropine, how to differentiate? If you do slit lamp examination and the pupil is torn, it means there is a sphincter damage. If you put diluted pilocarpine, see, diluted pilocarpine in the entire world can constrict only AD's pupil because of hypersensitivity. It cannot constrict a normal pupil. For normal pupil, 1% pilocarpine is required. But if there is no constriction and you put 1% pilocarpine, constriction takes place. It is third nerve palsy. Why? Because if the cycloplasia is blocking the receptors on which the pilocarpine works, how can pilocarpine work? In pharmacological cycloplasia, atropine blocks the receptors of the iris on which the pilocarpine work, so it will not be able to constrict. That is how you can differentiate dilated pupil examination. So AD's pupil is best appreciated in, all these are best appreciated in light conditions, because in dark both pupils are same size. This is known as anisocoria. Aniso means difference, coria means pupil, more appreciated in light condition in AD's pupil. So see this very carefully now. Is there any anisocoria? No. Bilateral, same size but myotic irregular pupil. What happens? Weak constriction, weak or absent constriction to light. In light, you put the light, pupil is not constricting, but it is constricting with near, normal or exaggerated with near. This is known as light near dissociation. Now, pretectal nucleus is involved only in the light reflex pathway. It is not involved in the near pathway. Near pathway, the light, the impulse comes directly from the visual cortex to the Edinger-Westphal. Pretectal is not involved in the near pathway. This is known as light near dissociation. That is seen two examples of light near dissociation. One is Argel-Robertson pupil, where the lesion is bilateral pretectal and a bilateral small pupil. Why small? It is a fact, we don't know the answer. And the other example is this. Just now I showed you this. With dark, both are same. With light, it is constricting, it is not constricting, means the pathology is in right eye. Near, it is constricting. Right, parasympathetic problem. This is a ciliary ganglion lesion known as AD's pupil, and it will, you tell me, if diluted pilocarpine you put in right eye, it will constrict. Left eye, it will not constrict because left is normal. Why in ADs the near reflex is present? हमें नहीं पता, idiopathic. But now we know accommodation near fibers are spared. That's why two examples of light near dissociation. One is Argel-Robertson, one is ADs. How to differentiate? Bilateral, unilateral. Bilateral myotic, unilateral dilated. Lesion pretectal, lesion ciliary ganglion. But this is a pathway coming from hypothalamus, superior cervical ganglion via the apex of the lung into the eye, postganglionic, dilating the pupil, sympathetic fibers. And the problem, sympathetic dilates the pupil. That's why if you see the pupil is smaller. That is seen in Horner syndrome. In Horner syndrome, pupil is smaller. And here the lesion I have given, for example, if there's a pre-ganglion lesion, which ganglion? Superior cervical. If the ganglion, before the ganglion lesion, apex of the tumor, apex of the lung, Pancoast tumor, preganglionic fibers are involved in Pancoast tumor, what happens? There is a preganglionic Horner syndrome. Pupil is smaller. Partial ptosis due to Muller muscle involvement. Muller muscle elevates the eyelid 1 to 2 millimeters, supplied by sympathetic. Difference of color of two iris known as heterochromia will be seen. It is congenital. Only in congenital difference of Iris will be there because during the birth, if sympathetic fibers are affected, then only it can be heterochromia. Now, if you get Horner syndrome, both iris are brown. Now, if you get Horner's, you will not have less color. Only when the melanocytes are developing at birth, then there will be heterochromia and congenital Horner's. Now, in Horner's, sweating should be lost. But sweating fibers, if you see, are coming directly from superior ganglion and to the face and neck. Eye mein sweating nahi. There is no sweating in eye or the face and neck. But the sweating fibers don't go into postganglion. So this is an example of preganglion. Here the sweating will be lost. That is anhidrosis. So you tell me in which example sweating will be normal. In postganglionic Horner syndrome, sweating is normal. Like in ICA aneurysm, like in cavernous sinus syndrome, sweating will be normal because the sweating fibers don't go into postganglionic pathway. That is the points you need to know for Horner syndrome. So let us see all these investigations. The first one, blue light. What is this contact procedure? It is a Goldman applanation tonometer. Applanation is the principle. What am I doing? It is using a fluorescein orange color dye, and whenever orange color dye is used, which light from the slit lamp is required? Cobalt blue light is used. And the reflected light will be green, and there are two prisms which make two semicircles. There are two prisms. The two semicircles should be equal in size and shape, and the inner edge of two semicircle meet. That is the correct intraocular pressure. It's the best tonometer, most reliable tonometer based on applanation principle. Which law? Imbert-Fick law. Second is a Short tonometer. That is based on indentation principle. Short's is indentation done in supine position. This is rebound principle, self tonometer, home tonometer. This is better for corneal opacities, that is tonopen. Indentation plus applanation principle. And what is this device? What is this? Not tonometer. This is gonioscopy for the anterior chamber angle. It is done by some lenses. It is also contact procedure. And if it is a contact, mask dekho madam ka. Anyhow, it is also used, done with slit lamp to know the anterior chamber angle by direct lenses, indirect lenses. Which one has a mirror? Indirect gonioscopy has mirrors. Direct does not have mirrors. Mirrors are there in indirect gonioscopy, and which principle is required? Total internal reflection in gonioscopy for the anterior chamber angle. So the exception, odd one out, is E. That is exception. Gold standard for IOP, intraocular pressure check, is Goldman applanation tonometer. Which one requires slit lamp? Both applanation, Goldman applanation and gonioscopy. But here the question is which require slit lamp with dye? Then the answer is Goldman applanation. That is again A option. Which is better in irregular or corneal opacities? Tonopen. Which is checking in supine position? Shorts. Odd one out? Gonioscopy. Example of direct gonioscope? Quickly. Coepe, Richardson, Swan Jacobs. Coepe, Richardson, Swan Jacob. Direct gonioscope does not have mirrors. Preferred in supine position, mostly in surgeries of the angle. Indirect gonioscopy has mirrors. Used in OPD procedure. Patient is in supine position, which I showed you the video was indirect. Goldman, Posner, Sussman. Goldman, Posner, Sussman, Zeiss are example of indirect gonioscopy. The entire primary glaucoma can be sufficed by this chart. Primary glaucoma, the pathology is in trabecular meshwork. You can't see the pathology. Only you can tell it's an open angle or a occludable. Occludable is closed angle. When the IOP is less than, normal is less than 21 millimeters, that is normal IOP. Optic disc is normal. He is a normal patient. Everyone does not have glaucoma. Normal insan bhi duniya mein hote hain. It's a normal individual. But if the normal pressure and the changes in the optic disc are there. See, this is the optic disc, best seen by slit lamp biomicroscopy. What is this change? This is a change in the optic disc known as a splinter hemorrhage. Splinter hemorrhage is an optic disc hemorrhage, particularly suggestive of a flame-shaped hemorrhage, suggestive of ischemia of the optic disc, hyperperfusion of the optic disc, that is seen in normal tension glaucoma patient. NTG means normal tension glaucoma. The pressure is normal, still there is a optic disc changes. But if there is a optic disc changes, like see, the cupping of the optic disc is increased. There is a thinning of the neuroretinal rim. Neuroretinal rim is formed by the nerve fiber axons, the papillomacular bundle, arcuate, and radiating fibers. The first one involved are arcuate fibers. That's why there is a vertical increased cup disc ratio. Normal more than 0.7 is abnormal cup disc ratio, and the vessels are coming and bending and coming out. Bending sign is known as bayoneting sign, because the vessels will bend from the edges of the optic disc and come out. That is bayoneting sign. So if there is an optic disc change with high intraocular pressure, high means more than 21 intraocular pressure with visual field change, that is known as primary open angle glaucoma. But if there is no ocular, if the ocular hypertension means optic disc visual field is normal, only the pressure is high, ocular hypertension. But if it is a closed angle glaucoma, normal optic disc, normal pressures, that is primary angle closure suspect. And similar to ocular hypertension, there is a primary angle closure. IOP is high, optic disc is normal. But primary angle closure glaucoma, the optic disc changes has to be there. Similar changes in open angle and closed angle. The first management in angle closure patient is laser iridotomy. You make a hole in the superior iris in the periphery so that the patient does not go into, I give you this, what is this? Pupil block mechanism. Pupil block mechanism, that is acute congestive glaucoma. Acute congestive glaucoma, acute angle closure seen only in small eyes, hypermetropes, which have small entry chamber, hypermetropes, in which the pupil is dilated. The pressure can go extremely high because there is a pupil block. 360-degree pupil block will lead to iris bombay and angle 360-degree closure, and what you have to do, iridotomy has to be done. That's why prophylactically in PACS, PAC, PCG, the first step is management is bilateral iridotomy in both eyes, so that the patient does not land up in an acute congestive glaucoma. In acute congestive glaucoma, there is a triad. What triad? Vogt triad. VOGT triad. Quickly, I will just revise. Pigment dispersion, mid dilated pupil, vertically mid dilated pupil, iris pigment dispersion, and glaucoma flecken, that is lens epithelium infarction. Vogt triad seen in acute congestive glaucoma. Now let us see these pictures. What is this sign? There is a blood in the anterior chamber, not the pus. This is red. This is hyphema. Blood in the anterior chamber. What is this? This is the pupil, and the iris is separating, causing an extra pupil, more than one pupil, polychoria. This is iridodialysis. So what is the history of blunt trauma is there? Which glaucoma? What is this? This is the iris has a reverse configuration. If there is a reverse configuration of the iris, particularly after exercise, increased pressure after exercise, reverse configuration of the iris, that is seen in a glaucoma. Reverse glaucoma, that is pigmentary glaucoma. In pigmentary glaucoma, there is iris pigments are lost. Increased light is coming from the retina. That's why iris transillumination defects. Some iris pigment can stick to the periphery of the cornea, that is Krukenberg spindles. That is known as pigmentary glaucoma. Mostly seen in young males. High IOP after exercise. Reverse configuration of the iris. So during exercise, the zonules and iris rub against each other. Iris lose the pigments, block the trabecular meshwork. That's why it is a secondary open angle mechanism glaucoma. But phacomorphic, the lens is swollen, it will push the iris upwards, secondary closed angle glaucoma. Phacolytic glaucoma, as I told you, secondary open angle glaucoma. Phacotopic due to subluxation, can be open, can be closed. If the lens is entirely in the anterior chamber, block the meshwork, open. If the lens pushes the iris, if iris is blocking the angle, then only it is closed. That's a very, very important thing. If iris is pushed or pulled and closing the angle, then it is an angle closure. Steroid, any steroid can cause open angle glaucoma. Topiramate causes lens swelling. If there's a lens swelling, it will push the iris, open, close mechanism. This is the most common secondary glaucoma, and dandruff like material can be seen anywhere in the eyes. Here I have shown you in the dandruff material along the pupil, that is pseudo exfoliation material. Pseudo exfoliation glaucoma seen in old age. It is the most common secondary glaucoma, that is pseudo exfoliation glaucoma. Initially it blocks the meshwork, so blocks the trabecular meshwork, the open angle. Later the iris is pulled upward towards the cornea, so it can be initially open, later closed. That's the most common secondary glaucoma, pseudo. So the child, the left eye is big bluish appearance of the eyes. The big eye, that is ophthalmos. Now this is seen in what? This is seen diagnosis is megalocorneum is increase the size of the cornea, or a congenital glaucoma. Megalocornea, there is no symptom. This bluish appearance is because of high intraocular pressure. the aqueous is coming and imbibing into the cornea, leading to corneal edema. So this is congenital glaucoma. Megalocornea will have only increase in the size of the cornea, nothing else, no symptom in megalocornea. So when the eyeball size is increasing, eyeball size is not increases in megalocornea. Booth thalmus' eyeball size is increasing. If eyeball size is increasing, cornea size will also increase, causing striations in the cornea, habstria, and which if the eyeball is increasing, it is axial myopia. And H for horizontal, H for habstria in congenital glaucoma, stria of the Descemet membrane, V for vertical, V for walked stria in keratoconus. What is the symptom of the patient of congenital glaucoma? So child will not have any symptoms, but mother can say, na? The father can also say if mother allows sometimes. So mother says, my child tried. 3 important. Most common symptom is watering of the eyes. He cannot look into the light, photophobia, squeezes eyes, blepharospasm. And there is a blockage of the trabecular meshwork by a Barkan's membrane. So Barkan membrane is blocking the meshwork. So cutting of the Barkan membrane is an angle procedure done by which gonioscopy? Direct gonioscopy. In supine, direct gonioscopy is preferred for angle surgeries. Goniotomy is the answer to cut the Barkan membrane. So congenital glaucoma also open angle mechanism because Barkan membrane is blocking the meshwork. Iris is not pushed or pulled. So congenital glaucoma is also open angle mechanism. Answer is goniotomy. But if there is a congenital corneal opacity or corneal haziness, then trabeculotomy plus trabeculectomy is done. Lotomy means to break the Schlemm's canal. Lectomy means to take a block of trabecular meshwork. So T and T procedure is done in congenital glaucoma with corneal opacity or corneal haziness. Otherwise, a single option treatment of congenital glaucoma, medical management does not work. Surgery of choice, goniotomy is a single best answer for general congenital glaucoma. But if it is mentioned congenital glaucoma with corneal opacity, then T and T, trabeculotomy plus trabeculectomy. So if you see, this is the observer's view, this is the optic disc, this is the central retina. Central retina is nothing but fovea, and this is the optic disc. The location of optic disc in the retina is nasal, fovea is always temporal. It is observer's view, so this is the right retina. This is the central lateral artery and vein. How to identify? The ratio of the artery and the vein is 2:3. So this is a central retinal vein branch. 2:3. The lumen of the artery is narrower than the lumen of the vein. And which pigment is maximum in the central retina? There are 2 pigments which are more. One is melanin pigment and one is xanthophyll pigment. They are more in the central retina, that is fovea. That is why chloroquine is a melanotropic drug, is causing macula, central retina problem, Bull's maculopathy. How many layers in the foveola? Foveola is a centermost part, 5 layers. Fovea has how many layers? 6 layers. Rest of the retina, macula and the rest of the retina has 10 layers. Macula is a central retina. Foveola, centermost, then fovea, and then macula, all in the temporal part of the retina. Now, if there is a less layers in the central retina, this investigation known as optical coherence tomography. That is a scanning only for the central retina, that is OCT. And in optical coherence tomography, this layer is a retinal pigment epithelium. That is the last layer of the retina. Why is the curvature like this? Because the foveola has 5, fovea 6, and central retina 10. There's a normal curvature, so this is normal. But you look at this OCT scanning only for the central retina, there is a hole. So this is idiopathic, mostly idiopathic macular hole. It is abnormal. This is normal, abnormal. This is also abnormal. What are these layers? These are the neurosensory retina. Neurosensory retina is the inner 9 layers of the retina. The last line is a retinal pigment epithelium. Separation of the neurosensory retina from the retinal pigment epithelium causing a subretinal space is a central retina detachment. This only the central retina is detached. That is central serous retinopathy, in which the outer barrier is formed by RPE and the first layer of choroid, that is Bruch's membrane, that is the outer barrier break. Management, nothing to be done. Mostly seen in young males, type A personality, under stress, interns, type A personality, taking oral steroids. Outer barrier break causing exudative retinal detachment, only the center. Observe for 3 months. 3 months only observe. If it is not resolving by 3 months, then photodynamic therapy is done. But this is the OCT in which central retina is not detached. The central thickness of the retina is increasing. This is cystoid macular edema. This is due to inner barrier break. Now, inner barrier is due to central inner 6 layers of the retina, central vessels endothelium problem. That forms the inner barrier. So if there is a central vessels endothelium and that is breaking, what is happening? Exudate is coming out, fluid is exudate is coming out, mostly goes into the outer plexiform layer of the retina. That's the plexiform, more space, increasing the thickness of the central retina, that is cystoid macular edema. Cystic spaces are there in the retina. Now this can be caused by drugs like prostaglandins, like myotics, like adrenaline. This can be seen in diabetic patient, venous occlusion. This can be seen after cataract surgery due to inflammation as well. If there is a problem in diabetes, the answer is intravitreal anti-VEGF injections. If the drug is a problem, stop the drugs. Management of post-cataract surgery, Irwin gas syndrome or uveitis, that can also lead to inner barrier break. Then the answer will be steroids. So treatment of CME depends on the steroids. Inner barrier break, outer barrier break, one example, central serous retinopathy, observe. But if there is a steroid intake of CSR, stop the steroids. Whenever drug is implicated, stop the drugs. So you have to match. I told you this one. This one is CSR, central serous retinopathy, outer barrier break. What is this? This is angiography. You put the dye in, antecubital vein goes to heart, retina, choroid vessels, arm retina time is 11 seconds. But if there is an outer barrier break, the dye will come into subretinal space, leading to ink blot appearance, smokestack appearance on CSR. Wait and watch. This is cystoid macular edema. And there is an outer plexiform appearance, radial configuration in the central retina, flower petal appearance. This is also angiography. How to differentiate angiography from autofluorescence? No dye is used in autofluorescence. That's why the retina vessels are dark. In angiography, the dye is used. Which dye? Fluorescein dye. Blue light comes inside, green reflected outside. Vibgyor. Low wavelength come inside, green reflected outside. That is seen in fluorescence property of fluorescein. Autofluorescence dye is not used, and lipofuscin has a property of any light you throw in the lipofuscin, it will emit the higher wavelength. Now lipofuscin in the central retina is seen in a condition known as Best disease. That is egg yolk appearance, but the vision is normal in egg yolk stage. Vision is decreased in scrambled egg stage. Best disease is a retinal pigment epithelium dystrophy. Central retina, the signs are more, the symptoms are less. Seen on autofluorescence because lipofuscin has a property of autofluorescence. Which is the other condition which is having symptom more, sign less? This is autofluorescence. Symptom more, sign less, that you see in Stargardt disease. So this is Best disease, but this is what? This is OCT, not central retinal detachment, because all the 10 layers are separated from the choroid. This is pigment epithelium detachment that is seen in age-related macular degeneration, which is matching to ARMD. ARMD has drusens only in the central retina, only the yellow colored drusens, no hemorrhages in the central retina. That is age-related end products in the Brooks membrane, first layer of choroid. Pigmentosa is a dystrophy of rods and cones. Rods are more affected. So rods and cones have A wave representation in ERG. So A wave is the early wave to reduce. Night blindness, bony specules in the periphery retina, tunnel vision differential. And in Stargardt's as well as Best, they are RP layer problem. In Best, the signs are more, the symptoms are less. And electrooculogram is decreased in RP layer dystrophy because electrooculogram represents a RP layer of the retina. And what ratio is there? Arden's ratio. And this one I told you, which one has more symptom and sign? The young male and young girl. Young male has so many daggers, still is saying sorry. You see in live, you see in similar to this, signs more, symptom less, signs less, symptom more. Stargardt's and Best. Both are RP layer dystrophy affecting the retinal pigment epithelium. Autosomal recessive condition, autosomal dominant condition. Signs more, symptom less, symptoms more, sign less. Patient will complain of decreased vision. Patient says, I can't see. Doctor says, I also can't see any sign because the signs are very less. Both will have lipofuscin deposition. Best in the center, Stargardt flex all over the retina. And dark choroid is seen in Stargardt because lipofuscin is covering the entire retina. choroid will not be seen. On angiography, there is dark choroid. So high myopic patient with floaters, positive scotoma in front of the eye, flashes of light with a curtain falling from above. A classical representation of retinal detachment, particularly rhegmatogenous. And which type? A curtain falling from above means superior visual field defect. There should be inferior retinal detachment. The management is vitreoretinal surgery. What is that? You take out the entire vitreous. Past planar route you come, take out the entire vitreous, complete vitrectomy. If you take out the vitreous, you have to replace by something. You replace by either oil or gas. Internal tamponade. That will cause the inner 9 layers to stick to the 10th. And in rhegmatogenous, you have to close the hole by either laser or cryotherapy. So 3 steps. Take out the vitreous, replace the vitreous by oil or C3F8, air, C3F8 or gas like SF6, and laser and cryo around the retina tear to close the retina tear. This complication is because of what? Gas or oil? Oil has a lighter density than water. In the anterior it goes up. So this is reverse, inverted hypopion, that is known as hyperoleon. That is a complication of silicone oil. That's why you have to take out the silicone oil after a few months of rhegmatogenous or vitreoretinal surgery. So now you tell me this is angiography or autofluorescence. This is right eye angiography hyperfluorescence, that is microaneurysm seen in first stage of diabetic retinopathy, seen in the nerve fiber layer, very mild NPDR. What are these? These are small dot and dot hemorrhages, intraretinal hemorrhages. These are not drusen's. Drusen's only in the central retina, age retinal macular degeneration. This is hard exudates, lipoprotein are coming out of the inner barrier. This is, both are seen in outer plexiform layer because they have more space. That's why dot and dot hemorrhages, mild to moderate NPDR condition is there. Now there is a 4-to-1 rule. 4-to-1 rule, I've just given some examples. Three conditions are there. 4 quadrant hemorrhages in the retina, 2 or more than 2 quadrant venous bleeding, 1 or more than 1 quadrant nirma. If out of these 3 only one is satisfied, that is severe NPDR. If 2 or all the 3 are satisfied, it is very severe. So 4 quadrant hemorrhages condition satisfied, yes. 1 quadrant venous bleeding, no, so it is severe. 4 quadrant hemorrhages, yes. 1 quadrant venous bleeding, no. 1 quadrant nirma, yes. So 2 are satisfied, very severe. And you tell me now this. 3 quadrant hemorrhages, no. 2 quadrant venous bleeding, yes. 1 quadrant edema, so this is severe, very severe. Write on your own, very severe in PDR. But in PDR, the last stage, diabetic patient, these are abnormal vessels in the optic disc. Not normal. This is new vessels on the optic disc. And new vessels anywhere in the eye. New vessels optic disc, new vessels elsewhere in the retina, new vessels on the iris, new vessel glaucoma. It is a proliferative stage. To decrease the ischemia of the entire retina, pan-retinal photocoagulation is done in the periphery of the retina, destroy the periphery retina, sparing the center. That's why the differential ring scotoma tunnel vision. Angiography, right angiography, what are these yellow arrows? Yellow arrows are hypofluorescence, means this is normal or ischemic retina. Ischemic retina produces VEGF, VEGF causes new vessels can leak the blood, it can leak the dye also. This white is, yellow arrows are ischemic retina, black arrows are new vessels. This is new vessels elsewhere and new vessels on the optic disc elsewhere. Still the stage is PDR, still the management is pan-retinal photocoagulation. These new vessels can pull the retina upwards, leading to tractional detachment, management vitreoretinal surgery. Take out the vitreous, replace the vitreous by oil gas, and intraoperatively pan-retinal photocoagulation, that is tractional retinal detachment treatment. Again, this is the right retina. All these red are now flame-shaped hemorrhages. Now this is also yellow, but these are fluffy margins, like a cotton wool spot. Cotton wool, if you have a cotton wool, fluffy margins, big fluffy margins. Now cotton wool spot is soft exudate, that is representing ischemia of the nerve fiber layer. And I told you in the optic disc hemorrhage, flame-shaped hemorrhage, that also represents ischemia. So this is, ischemia is more in this picture. All the quadrants have flame hemorrhages. Now hypertension is causing the thickness of the artery, walls are thick, it can compress the vein at the optic disc, leading to splash tomato appearance. Central retinal vein occlusion is the answer over here. That is a complication of hypertension retinopathy. The problem is not in the vein, the artery wall is thick, compressing the vein. And in hypertension, the ischemic signs are more. Flame hemorrhages, cotton wool spot goes in favor of hypertension. Hard exudates and dot hemorrhages goes in favor of diabetes. And here also it can be ischemia, VEGF, NVI, NVG, NVG can take NVI to NVG, neovascular glaucoma take 100 days. 100-day glaucoma, neovascular glaucoma is a secondary glaucoma seen, 100-day glaucoma specifically seen in CRVO. It can be open close. Initially it can block the trabecular meshwork open, it can pull the iris upwards towards the cornea, later on close. Same as pseudo exfoliation material glaucoma. What is this right retina? Edema in the periphery of the macula, sparing the fovea. This is nothing but cherry red spot. In cherry red spot, the problem has to be in the ganglionic layer. Ganglion is maximum at the macula, but ganglionic layer is not present in the fovea. Fovea only has 5 and 6 layers. So ganglionic layer is spared, or ganglionic layer is involved. Fovea is spared in cherry red spot. Fovea is spared. Fovea is involved in which condition? Bull's maculopathy, chloroquine I told you. Now child with cherry red spot, mental retardation, skeletal muscle weakness and organomegaly not present. That is Tay-Sachs disease. But if the organomegaly is present, the answer will be pediatrics, Niemann Pick. And two ocular conditions, one is central retinal artery occlusion and what is the capital of Germany? Berlin's edema. Both have ganglionic layer edema, sparing the fovea. So Berlin edema is seen in what? Which trauma? Blunt trauma. All these signs, let us see. What is this sign? Periorbital hematoma, ecchymosis. This is blood in the anterior hyphema. The major arterial circle at the periphery of the iris bleeds. This is separation of iris from periphery, causing a D-shaped pupil, iridodialysis. Multiple pupil, polychoria. Pigments, brown pigment of the iris on the lens. Which ring? Vossius ring. Which cataract? Rosette cataract. And this radiology question. This is floor fracture of the orbit, because that's the weakest point of the orbit. Maxillary bone fracture, that is blowout fracture, teardrop sign goes into the maxillary sinus. All are seen in which trauma is this? Blunt trauma. But sympathetic ophthalmia, the next question, that is not seen in blunt trauma, that is seen in penetrating trauma. Which type of uveitis? I am not taking uveitis, but it is a bilateral granulomatous uveitis. What is a foreign body? Whenever word come, it has to be penetrating trauma. Most common foreign body is iron. Some people do chisel and hammer injury. And investigation is MRI is contraindicated, a non-contrast CT scan. And siderosis is the answer when there is a iron foreign body. Because when you call chalcosis, copper foreign body. Which cataract? Sunflower cataract. Case of stress ring in the cornea, which I am not taking. Chalcosis, Wilson's, both can have case of stress ring. Now some PSM questions. Most common cause of blindness in more than 50 years of age is nothing but senile cataract. But less than 50 years of age, not refractive error, I'm asking blindness. That is corneal opacity due to any cause. Mostly traumatic, mostly after infectious keratitis, mostly can be vitamin deficiency. Any corneal opacity is the most common cause of blindness less than 50 years of age. Vision impairment, and what is the definition of blindness? When the visual acuity is less than 3/60 in the better eye with available correction, as told by India. WHO has best correction. India is available, whatever is available with the patient. Okay. WHO says best correction, they will give spectacles. India says we will not give spectacles, whatever patient brings. Available correction in India, less than 3/60 is the definition of blindness. Vision impairment. Senile cataract is the more than 50 years. Vision impairment less than 50 years, then refractive errors. Irreversible blindness, glaucoma. And childhood blindness is vitamin A deficiency. Most common cause of preventable blindness, senile cataract. Of course, vitamin A you can prevent, but incidence of senile cataract is more, na? So PSM, please, PSM people tell. Most common cause of preventable blindness is senile cataract. You're not preventing cataract, you're preventing blindness from cataract by doing cataract surgery. But in child, you cannot tell the visual acuity. So for visual acuity in the child, two tests I've given. One is Teller's chart. Now Teller's chart is a preferential acuity test. This is a vision testing in child. There is a hole in the center. The doctor observes the direction of eyes. If the child has a good vision, he will look at the pattern. He will not look at the empty space. So if the child is looking at the pattern, the doctor will see the child is having a correct direction of the eyes or not. If he's looking into the empty space, the vision is not good. So it is an objective test. Why you make the hole? Why can't the doctor see from above? Because child will be distracted by you. Aap sundar hai. You're handsome, na? Beautiful. The child will be distracted. So you have to hide behind the chart and see the child. And again, a vision testing for child and also for malingering is optokinetic nystagmus done. Now it is based on two movements. It is used for malingering also. If you rotate a drum at a very high speed, involuntary nystagmus occurs. Involuntary. So if the patient is lying and you rotate the drum, if the nystagmus come, it must be lying. ठीक है, आप patient झूठ बोल रहा है, आप drum घुमा दो. अगर nystagmus, if the nystagmus is there, patient might be lying. So it is based on two movements. One is pursuit and saccade. Now what is this pursuit saccade? If you rotate a drum at a very high speed, what happens is this is a slow movement pursuit. So for example, I explained this in the class like this. Na? If there is a pursuit and there is a saccade like this, so what happens if someone is going in front of your eyes? You know, someone, you are sitting in a park, for example. Anyone can sit in a park. For example, any young male of you is sitting in a park, and this object is going from left to right, and you are observing. This is slow, smooth movement pursuit. You do this slowly only. So this is controlled by same side occipitoparietal lobe. Object is going from left to right occipitoparietal is stimulated. But sometimes you are doing slow, smooth pursuit and another object comes here. Then what do you do? Look at this object or look at this. Look at the other one, fast. This is saccades, controlled by contralateral frontal lobes. And if you want to see both, what happens? Pursuit, saccade, pursuit, saccade. That is optokinetic nystagmus. If you rotate the drum at a very high speed, slow movement pursuit, saccade, involuntary nystagmus occurs. That is, these two movements are required in this objective test, that is OKN. If you sit in a park and do all these things, this is the end result. What is the sign? Bilateral ecchymosis. That is known as panda eyes or raccoon eyes. That can be seen in blunt trauma, yes. If you do all these pursuit saccades, it can be seen in child with bilateral ecchymosis, neuroblastoma. Most common bilateral proptosis in a child. Most common unilateral proptosis, I'm not taking, orbital cellulitis. Fracture of anterocranial fossa. And of course, if you do a lot of pursuit and saccades, blunt trauma to both eyes. So I want you to solve 10 questions for me, please. What is the angle total 6 by 60 letter subtends? MAR is 10 minutes, total 10 into 5, maths 50 minutes. Answer, speak loudly. I can't see, I can't hear. A, say A. I can't hear. I'm sitting in the back. देखो पीछे मैं बैठा हूँ. नहीं बैठा. A is the answer. What is this? Visual field, patient's view. Left heminopia with macula sparing, right occipital lobe lesion. Ring scotoma. Which drug? 2. Vigabatrin, quinine. C. Say C. C. Now say loudly. Hydro dissection. B. Vinod. Which splash appearance? Diabetic retinopathy or no? CRVO. 100-day glaucoma. CSR or CME? Central detachment? No. Patient is taking no chloroquine. No, that is to distract you. Rheumatoid arthritis. This is cystoid macular edema. That is inner barrier break. Flower petal appearance on angiography. How to calculate the spherical equivalent? Spherical power as it is, half the cylinder. A is the answer. Speak A. Bolo A, bolo. 55-year-old man, glare after cataract surgery, difficulty driving at light, cataract surgery 4 years back, posterior capsular opacification after cataract. Most common complication of cataract surgery. What are these? Drusen's, hard exudate or soft? Not soft, these are not cotton wool spots. This is, Drusen is not an option. Hard exudates, outer plexum layer, diabetes mellitus. And the last, bola tha na, mother says, father sometimes says, big blue eyes, congenital glaucoma, watering, high IOP. Megalocornea will not have high IOP. And see this. What is the first symptom in this syndrome? Now I gave this in last DVT as well. Now if you're answering the question, then you're making a big mistake. Because this male young, there is no syndrome as male young. Reverse it, this is nothing but young male. So what I'm trying to say, there's no syndrome like this. There will be some questions in the exam in which you don't know anything about that. What do you have to do in that? Leave the question. Because there is no question like this, no syndrome like this. The message is to leave such questions which you have not seen anywhere, and there will be some questions in the exam which you have no idea. This is nothing but our young males from the class. Chennai, Valivans, Vayasu Payans, Kannada Hudugas, like Vayasu Karadu of Andhra, and Buddhimutu Malayalam, Cherupakkaran, Mulga of Maharashtra, Juvan Chokras of Gujarat, and Tokas of Odia, Dekalora of Assam, Jawan Londa of Punjab, and of course Hindi Heartland, Jawan Hamare Ladke. All these are young males. This is also eye of a young male. I told you I'll show you this picture. Whose eye is this? Try to identify. This is nothing. This is the person because of what? Because of whom we all are here, sitting here. This is the right eye, left eye? Right eye. And see, this is one of the DVTs which happened many years back. And see, still he might be sitting somewhere else. In this white shirt, he might be sitting. Nowadays, he wears something else, shirts also, t-shirts also, but usually he used to wear. So he's sitting in a DVT like this, and such a big person and still a little humble. So the last message from my side is be humble in the life. Whenever you reach, humility is the one which you should never leave. Tell a story, this well and a river story. Just I'll tell you one in Hindi and one in English. Similarly, I'll translate. So there was a river, a big river and a small well. The river told well that see, well, you are very small. What is your status in life? तुम इतनी छोटी हो, मैं इतना बड़ा हूँ. रिवर ने बोला, क्या तुम्हारी औकात, ऐसे बोला उन्होंने, क्या तुम्हारा स्टेटस है लाइफ का. So the well, in very humility, very small well, said that there is a difference of stagnation and wanderness. वेल ने बोला स्थिरता और वॉन्डरनेस में कुछ तो, ठहराव में और भटकाव में कुछ तो फर्क होता है. Then the well said that a thirsty person comes to me whereas river goes to the thirsty person. वेल ने कहा कि एक प्यासा इंसान मेरे पास आता है और एक रिवर है जो थर्स्टी के पास जाती है. And then the last, in a very humility, well said that my water comes from below and becomes sweeter. You comes from mountain and becomes salty when you go into the ocean. So the well, in all the humility, is the one which should be there in our lives wherever we reach. So one crunch of DVT which I am selling you, kuan bano, well bano. Thank you very much. Thanks for listening. Best wishes.